Hello, everybody. The first one is to answer a clinical question that we used to have in the past. And I think for both presentations, it's important to mention that I have no clinical interest, no financial interest in Seeso Italia products. Since 2004, I've been using Scheimpflug imaging to assess my patients after refractive laser surgery, after cross-linking. May I ask you how many of you perform cross-linking in the audience? Many, many. And you probably do more or less the same. I had a Pentacam for all these years, and this was my go-to device, a Scheimpflug imaging device that takes a series of pictures rotating around the eye. And what I was interested in, let's say after a deep PRK or after cross-linking, was healing and haze. So I really like the densitometry module of the Scheimpflug machine. I know it's a CSO user meeting. I start with Scheimpflug imaging and showing you Pentacam images, but you will see why. So I look at these images, and then I have the patient come back after 1 month or after 12 weeks. Why? Because I want to see how is the healing. Is the healing massive? Do I need to give more or less steroids to influence the healing? And this patient came back after 12 weeks with a lot of haze, and the densitometry module is fantastic to monitor haze. It's diffraction of light, right? And densitometry, haze means invasion of granulocytes, neutrophils, inflammatory cells into the cornea, more diffraction of light, higher densitometry values. So this is a really nice tool to say, okay, you're healing too fast. I need to give you something to slow down healing, dexamethasone, and 12 weeks later, the haze is gone. This is an ideal situation. This is how I used to monitor my patients. So Scheimpflug has a fantastic advantage, but this fantastic advantage is also the biggest disadvantage of the technology. So when I want to monitor haze, densitometry is fantastic. When I want to see K readings, it's bad. Why? Because of the diffraction of light. Let's give you a first example. This is a patient I've seen after a hypermetropic PRK. This patient had a PRK for +3, came to me 2 years after the PRK, and again was at +3. Can we do something that techniques, we show a lot of colors, and the colors are all off. It's hard to see the colors. So the patient had, if you can see it, this is, I think, the right eye, so this is on the temporal side, had a huge depression in Scheimpflug. Here, let me show you. Here, there, right? A huge depression. So I was thinking, how can I correct for this? It's a surface ablation, it's after 2 years. Can I do a corneal wavefront guided PRK on top of it? So I looked at the Sirius data, and the Sirius data were very similar. Well, Sirius is a combination of Scheimpflug and placebo, right? Shows you the same depression. So what would your approach be to improve this rather big horizontal coma? What would you do? I considered at the time a corneal wavefront guided trans-PRK until I saw the MS39 data. Look at this. There is 0 horizontal coma, nothing. What happened here? It's the haze. It's the peripheral haze of the PRK that completely screws up the Pentacam interpretation or the Scheimpflug interpretation. So Sirius and Pentacam had a big problem because of the superficial scar. And so what I saw in these measurements was not correct. Before I had an MS39, I would have taken Sirius data and would have made a treatment that was not only unnecessary, but working with the false data. Now, if I show you the densitometry value, this is an MS39 image. If I show you the densitometry values of the Pentacam, you clearly see the huge increase in densitometry where the scar is. So please always keep in mind that anything that disturbs the ray of light in your cornea can totally disturb Scheimpflug imaging. And when we realized this, we asked ourselves, wait a minute, what do I do after cross-linking? Patient comes, after how many months do you usually check your patients for success? How many months? Just
1 year.
12 months? Do you have other opinions? I usually do 6 months, and I check my patients, right? I want to see what has happened to that cornea. Which device do you mainly use to check your patients? Let's say before 2020, what would you have used? Apparently, if you're here, you're all MS-39 users or soon to be users, but before 2020, 2019, what did you use? Sirius. So that's a Scheimpflug imaging system with Placido. Now, what we did is, we said if haze disturbs the image, let's revisit success rates after cross-linking. And we were pretty surprised. So I measure after 6 months, and the question was, do we really see reality in Scheimpflug images after 6 months? So we took 3 different cross-linking protocols, and we checked the cross-linking success in the same patient using, in this case, a pentacam and an MS-39. But it's important to say we could have used a Sirius and an MS-39. It's not inherent to pentacam, it's inherent to Scheimpflug technology against OCT. Now let's check the accelerated PROF protocol. And we check the success rate, and that's important. I don't want to discuss a biblical discussion about progression and definition. No, me, with my experience, I looked at the images and I simply assessed, do I need to treat the patient again, or is he stable, or is he or she better? And so this is what we saw. So in pentacam, I had stabilization. In 22 of 26 cases, we looked at a total of 26 cases here. In the MS-39, I had a little more cases with stabilization. The progression rate was the same. I saw improvement in a few pentacam cases where the MS-39 simply said stable. But luckily, this does not change my clinical decision making. Stable or better means no more action. Patient is okay. Which means if we look at congruency between the 2 technologies, we were congruent in 17 of the 26 cases. Just by looking at the 4 standard maps of the pentacam and the standard maps of the MS-39. If I take the Bellin progression display into account, I could increase by 3 more patients the congruency, and by using the keratoconus progression tool of the MS-39, I went up to a total of 21 out of 26 where we were congruent. But we still had discrepancy in 5 cases. Let me show you one of these cases. Here, for example, yeah, it's the colors, but you can see that the left has a steeper cornea than the one at 6 months. So this was an improvement. An improvement that could not be seen in the MS-39. Why? Let's look at densitometry in the pentacam. These are pentacam images. As you can see here, there is an issue in densitometry exactly where the pentacam suggests flattening. So this is a false reading. If you look at the MS-39 data of the very same patient, no flattening, just stability, which is good also. See, these 2, flattening of 2.5 diopters, and at the very same place, 0.3 diopters, no change. If we go higher with fluence, which means more stress to the tissue, more haze, it gets quite drastic. If we go to 10 joule, that's a new protocol we developed that is very fast and as strong as Dresden protocol, but only 9 minutes. Then you have big differences. Look at these. So we have stabilization in 15 out of 26. The MS-39 showed us more improvement, but what is really a little upsetting is in 6 cases, the pentacam suggested worse. You have to retreat the patient. And the MS-39 had no progression in any of these 26 cases. So here, I changed my clinical attitude in more than 20% of these patients. I would have told them, I'm sorry, you're among the few where cross-linking didn't work. I have to re-cross-link you. With Scheimpflug, if I had an OCT-based analysis, I would have told them, you're good. So really a big discrepancy, and as you can see, much more discrepancy. And Again, as I said, 20% of difference. Let me show you an example. Let's see how the colors are now. This one here, look at the difference image in the pentacam. So an increase of more than 2.5 diopters after 6 months. You would all agree if this was a perfect measurement, that's strange after 6 months. Look at the densitometry. It's exactly where the steepening is. And again, if I show you the same patient recorded on the very same day, nothing at all, and even, let's make this bigger, even a flattening of 3 diopters. So 6 diopters or 5.5 diopters of difference between the two technologies. That's not 0.5 or 1. Ricardo will show very interesting data in a few minutes. I think that go into a similar direction, but the pentacam and the MS-39 give you completely different readings. And then we have second generation customized cross-linking PACE. I only show this to you because on a small surface of the cornea we use almost 15 joule, so even more. And here, PACE is not about getting worse or stabilizing. It's all about improving. So most of the patients improved, but we had in 2/3 of the patient, we had more than 30% of difference in K readings. So the higher you go with your healing reaction, the less reliable Scheimpflug technology becomes. So in conclusion, beware of limitations of Scheimpflug. I still use it every single day because it helps me a lot to monitor the healing. In a perfectly transparent cornea, Scheimpflug is awesome. It works very well, but as soon as you have haze or scar or anything that disturbs the light, just know what you are measuring. And we are revisiting now our success rates of the last 5 years, and we should soon have all the data, but it seems as if the success rates of the cross-linking are way, way higher than we thought because we don't measure correctly afterwards. If you want to learn more, we are having our cross-linking experts meeting for the 20th year in Zurich, and this time there is a K in front of CXL because we will also include the keratoconus experts meeting that we held with Jérôme Frickem the past 10 years at ESCRS. So it will be a much bigger meeting. Please join us in Zurich. Thank you.